Hey everyone, good morning. We'll get started here in just a few minutes. I don't know if you can't hear me. Just let me know if you guys can hear me or not, just so I know things are working. Good morning. At a Monster, at a Red Bull, a no dose, I think I am plenty energetic. Like, quiz went pretty well, so it's good. It's good morning. Someone says I have low energy. I say I resemble that remark. Morning, Shamir. I should have cardio part 1 up. That's what we're going to be starting up here. Can't access the PowerPoint. Huh. Look. Vibing right now. Maybe that's the adjective I've been seeking. You know why you can't access the PowerPoint? Probably because I haven't published it like here. Try accessing the PowerPoint now. It should be there. Useful if you click the button to help publish it. It's too busy making sure your quiz was going to go well that forgot the other important component. All right, let me get started. All right, well, welcome everyone. Hopefully the quiz went okay. If you have any questions about it, I'll check out the stats and see if you make any changes there. But it looked like everyone did fine. So I'll you can send me an email if you have any questions or anything. So the PowerPoint is there on Canvas. So you can pull that down. This is mainly focusing on our medications for dyslipidemia. So this is cardio part 1. We'll get into actual meds for like hypertension and stuff at a later PowerPoint slide set. So we're going to focus on our lipid lowering agents. Why do we care about this? Because having too much lipids in the blood is going to lead to things like atherosclerosis and leads to inflammation, and that ultimately leads to things like myocardial infarctions and strokes and peripheral vascular disease and all kinds of things. And so that's what we're going to be focusing on, trying to maximize our lowering of things like LDL and trying to maximize HDL and things like that. They're going to overall help to prevent mortality in our patients here. So basically we have two sources of dietary fats, right? So we have dietary fat coming in from the food and then also cholesterol coming in. Also recall that there are the bile salts that get eliminated through the biliary tract, which are useful for helping to sort of start to break down that fat. It emulsifies it and breaks it down into smaller components, which we can then absorb from the GI tract, right? And there's a very cyclical sort of nature to all of this. Obviously, we have fat coming in from the diet. We also have adipose tissue where we're storing a lot of this, but also other peripheral tissues that utilize cholesterol and things like that to produce hormones and We utilize triglycerides to help produce our cell walls and all kinds of things we're using these fats for. So they're very important. But the other main organ we're going to see that's important here is going to be the liver, which will help us to sort of recycle the fats here between the bile salts that will help to uptake the fat from the tissues and from the bloodstream and be able to use it for all sorts of things. So we're going to look at this like a little bit more in depth and how we can affect that with our medications here. And so we can see that the dietary fats we're taking in is usually comprised of triglycerides and then cholesterol. And when those are getting absorbed from the GI tract, they get incorporated into these things called chylomicrons. You can kind of see here, even though it's a little bit less clear because it's a white background, but you can see the dietary cholesterol and biliary cholesterol. So this is what's being sent out by the gallbladder is coming in. They will break it down into smaller and smaller components, which are able to be absorbed through these cholesterol transporters and into the enterocytes, and then that's where that chylomicron gets formed. This is what's getting absorbed from the GI tract to then be transported to the liver. And so what you can see here, these pictures kind of show you the breakdown between triglycerides, which is the green component, and then the cholesterol esters, which is the yellow component here. This chylomicron's coming from the intestine and then will be sent over into the liver. This is one of the most important organs in terms of affecting our balance of cholesterol in the body, as we're going to see here. So very important component here. You're going to have some changes here, those chylomicrons, some of that can be utilized for things like producing hormones and things like that, but eventually it's going to get sent out into the bloodstream for it to be transported to all the tissues in the body. And so this is where your VLDL comes into play, and notice here that a lot of it is triglycerides. So when you look at things like a lipid panel and you look at the triglycerides, you're mainly looking at the VLDL component of what's there in the blood. And you'll see that as you start to metabolize off some of these triglycerides, you're going to see that the component or the proportion of cholesterol esters actually goes up as you start to get rid of more and more of those, usually through enzymes like lipoprotein lipase and stuff, which I'll mention here in a few moments. But VLDL eventually turns into IDL, which is intermediate density lipoproteins, and then we get to our LDL. And most people have probably heard of LDL before because that's what we think of when we hear like the bad cholesterol, right? And so that can be taken up into the tissues. It can be utilized for all sorts of things, as I mentioned. Eventually, the macrophages will start to take these up and then convert them eventually into HDL, which we think to be our good cholesterol, right? Again, this whole process here is cyclical. It's going to be, some of this LDL is going to be taken up by the liver. That's where we can form things like bile salts and whatnot. And so we're going to be trying to affect this in a lot of different ways with our different classes of medications here, okay? And you can kind of look here to see the various ratios here between triglycerides to cholesterol ratios. I'm not going to ask this on a test specifically, but what is important here are going to be things like, where are these things being made and how can we affect them with the medications, and then how do we get rid of them? So for instance here, like the VLDLs and triglycerides are being made in the liver. So if we can stop that production, we know that VLDLs are precursors to LDLs, and if we stop that production in the liver, then perhaps we can decrease production of LDL down the line, right? So that could be an important component there. The other big thing you're going to see too is that the LDLs are going to be taken up by these LDL receptors, so this LDLR, so that's going to be a really important component here. You have LDL receptors on like the muscle and the fat that can take this up, but also you're going to have this on the liver, and that's another really important component here to consider. So those are kind of the things I want you to kind of glean from this this table here. So anyway, so as I mentioned, the LDL particles are arising from breakdown of the intermediate density lipoprotein. And there's an important thing here. There's a sort of a surface protein that it has on the surface of the LDL molecule called ApoB100. And this is what actually binds to the LDL receptor. That's what allows it to be taken up out of the blood and into the tissues, the liver, etc., right? And so looking at that, you're going to see that if you are missing this ApoB100 protein, then you're not going to have a very easy time getting rid of that LDL. And you can actually find genetic deficiencies in that protein that lead to people having extremely high LDL levels, right? And so if you have that, or if you're missing LDL receptors for whatever reason, then you're also going to see that you can't clear them very well. So why do we care about LDL? Why is that such a problem? Well, it's because if you have this accumulation of it in the blood, eventually it accumulates in places like the vascular endothelium. And if that happens, that's where you start to get thickening of the vessel walls. That's where you start to get those atherosclerotic plaques that can break off and can lead to, MI, can lead to all kinds of problems there. So this is the thing we're trying to prevent. You can prevent that, you can keep the vessels nice and clean and open, then you can keep your patient alive for longer, okay? And so here's an example of what that LDL molecule would look like with the ApoB100 protein at the cell, at the surface. It's not really a cell, it's like a molecule at the surface here. And then the LDL receptor. So say for instance, if this was say a muscle cell or a liver cell or anything like that, it will then interact just like any drug in a receptor would, and then it will then internalize that through endocytosis, right? So then engulf that. You can then utilize the lysosome to then break that down to extract things like amino acids and cholesterols and all that, because it's needed for, normal cell function. And then when it's finished, it will then send that LDL receptor back up to the cell surface where the whole cycle can repeat again, right? But what happens if what if these cells are already just chock full of LDL because the patient has chronically high levels? Well, all these LDL receptors here, they're going to be like, well, we have enough here, so we don't really need to take any more out of the blood. And so this shuttling of the LDL receptors back to the cell surface is going to be downregulated, right? So as you find that if you have high intracellular levels of LDL already, then you're going to have fewer receptors up at the top at the cell surface here. If I have relatively low levels within the cell, then you're going to find that your cells are saying, I need more LDL, so it's going to put more receptors at the cell surface. Okay, that's a general caveat with a lot of the medications we're going to talk about. And we want to maximize as many LDL receptors at the cell surface, especially in the liver, to get as much LDL out of the blood as possible. And that's going to help us to reduce atherosclerosis and inflammation and all kinds of bad stuff for your patients. So here are where the different medications are going to be working that we're going to get into specifically. You need to know where the drugs are working, how they're working, in order to understand what sort of effects they're going to have, what sort of side effects you can expect, how they might work synergistically with one another. And so that's what I'm going to be focusing on here, and you can kind of refer back to this picture as we go through it. Here are the different classes we're going to talk about. We have our HMG-CoA reductase inhibitors, which are colloquially called the statins. We're going to have our cholesterol absorption inhibitors like ezetimibe. We'll have our fibrates, bile acid sequestrants, nicotinic acid derivatives, and then our PCSK9 inhibitors. This is sort of the newest class out of the bunch here. So to talk about the statins first, and when it comes to management of dyslipidemia, statins are king. Like these are going to be the go-to medications for almost every single patient. So because the guidelines have really changed over the years and have really sort of put more and more emphasis on the statins. I'll talk about why that is here in just a moment. How do you recognize a statin? Well, it's pretty easy because they all end in statin, right? So lovastatin, simvastatin, pravastatin, fluvastatin, atorvastatin, rosuvastatin, and pitavastatin. Probably sound like I'm chanting some kind of demonic ritual or something when I keep mentioning these similar sounding words over and over again, but again, I do it so that we at least have some idea of how to pronounce these sort of drugs here. But regardless, looking at how these drugs work, right? So basically, there's a very long, complicated, multi-step process to actually produce cholesterol within the hepatocyte itself. And you can kind of look at these pictures here. The left side being the hepatocyte, the right side being the systemic circulation, and there being this sort of cycle here. If we can reduce the amount of cholesterol synthesis within the hepatocyte by blocking the enzyme HMG-CoA reductase, you're going to find that the actual concentration of intracellular cholesterol goes down pretty significantly, okay? So you're blocking the production of cholesterol synthesis. What that's going to do for us is a couple of things. One, the hepatocyte says, well, I don't have enough cholesterol in here anymore. I need to start upregulating LDL receptor synthesis. I need more LDL receptors at the cell surface in order to take up more out of the blood, right? Because if it can't make it in the hepatocyte, then it's going to be sucking up out of the blood, right? The downstream effects as well is if it can't produce as much within the hepatocyte to send out into the systemic circulation, that means your LDL concentration, or I'm sorry, your VLDL concentrations and thus triglyceride levels are going to be going down, okay? By reducing those, you're going to see that you're reducing your LDL, your VLDL, and ultimately you'll have actually some bumps in your HDL as well, even though that may not be sort of the the biggest component. Yeah, so Josh is saying, wouldn't that lead to a decrease in HDL? Clinically, that's not what we find. And again, there's probably a much more complicated biosynthetic, process to that, but not necessarily within our scope to cover all that today. So just know that ultimately we're reducing production of LDL, some triglycerides, and you'll see a bump in your HDL. It's not going to be like the biggest one. There's some drugs that are a little bit better increasing HDL than others, but certainly you'll see some increase, right? And so anyway, so we're sucking up more LDL out of the blood because the cholesterol or the liver can't make it, and then we're also producing less and sending that out from the liver, so you have less triglycerides being made here. Okay. Now, there's also, like, that's all well and good, right? So you get your LDL levels down, but that's not necessarily the thing that keeps patients alive, because we have plenty of drugs that reduce LDL concentrations, but we don't see the same sort of mortality benefits like you might see if you have patients who are taking a statin versus other drugs, right? And so we're like, well, why the heck is that? Why is it that you would have patients getting so much better benefits out of the statins here? And so what they're finding is, and even if we don't have a full mechanism for this, they have what they call these pleiotropic effects. And this is a very fancy word you can use on rotations and to make yourself sound quite smart. And so what this means, pleiotropic means they're sort of like side benefits, right? So, it's like if you drive a Tesla, like, yeah, you got a cool car, but also like you're helping the environment. It's a pleiotropic effect of a Tesla. I don't know if you're into those cars or not, but so statins have a lot of pleiotropic effects, right? So they do all these things here. We notice they help with things like atherosclerotic plaque stabilization. So they prevent those plaques from breaking off and eventually causing an embolus and MI, right? They help out with inflammation. They help out with blood pressure effects. They help out with angiogenesis and helping with reperfusion of ischemic tissue. They do all these things, we notice. We don't necessarily know why, but they do. And so because of that, that's why we see much better mortality benefits out of drugs like statins than you do with really any other class of medication for dyslipidemia, which is why we focus on it so much and why this is going to be kind of the main treatment for majority of your patients. Sounds like I have a little one trying to break into my room, so we'll see how that goes. Anyway, so here's kind of the list of the various statins we have available to us. Basically, there's a lot of numbers here, but the main thing I want to focus on are going to be sort of the metabolism components here, right? So as you'll notice, there are many of the statins that are going to be substrates for CYP3A4. And so that's going to be a bit of a challenge when we get into some of our other medications that can inhibit CYP3A4. We've already talked about several, like the macrolides, for instance. And so this can be problematic from a side effect profile. While the statins seem like they're great because of all these additional benefits they have, they can also be quite toxic if not managed appropriately. And so that's kind of the other major drawback to the statins. There's going to be some issues that we can talk about here. So it's good to know like where these are getting metabolized, and if we are going to have a medication that's going to inhibit CYP3A4, we need to know which statins to skip, right? To utilize, when we should skip using something like atorvastatin in lieu of something else, because of the fact that you're going to have this really significant CYP interaction here if you're not careful, okay? So again, this is why you always want to check a medication list. You always want to look up an interaction report to make sure you're not going to add something onto a patient's regimen that's going to eventually lead to, significant harm down the line there, okay? So what are some common side effects of statins here? So certainly some like headache and GI intolerance and things like that. You can get some flu-like symptoms. So kind of like, this like fatigue and kind of these myalgias that can occur with statins are pretty common in a lot of patients, especially if the levels are sort of too high here. The other thing too is it can cause liver dysfunction, which makes sense because it is working directly there in the liver. It's not exceedingly common that you're going to have to stop a patient from taking a statin altogether because of increases in LFTs, but it's common that you're going to be monitoring for this. It's common that you may need to reduce a dose if you do see levels start to increase here. And so basically what you're going to find is that you want to, the baseline, get a patient's LFTs done prior to starting statin therapy to see what their baseline is, and then have them check up like in, say 4 to 6 weeks after starting a statin to come back to see what their LFTs are doing. And if they've risen, say greater than 2.5 times what their normal is, then that may be a pretty good sign that you need to either reduce the dose or DC it altogether, because they're having either too big of a dose, maybe there's a drug interaction, or they're just really sensitive to the effects of statins, and that's where you can run into some problems there, right? It's exceedingly rare that you're going to get like fulminant hepatic failure, but it can occur, and so you do want to be watchful for that. I mentioned the flu-like symptoms, and myalgia certainly is going to be a concern there. And again, a lot of these patients, you think about those with like, metabolic disorder, hypertension, dyslipidemia, diabetes, all of that. These chances are not going to be the most active patients in the world. And so, if they call up and they say, hey, I started the simvastatin last week, and, I've been sitting on my couch all weekend, but I feel like I just ran a marathon, that could be a sign of myopathy that is occurring there, and you do want to be warning patients about that because this can be fatal if not caught and managed early. And myalgias, while common, the myopathies are fairly rare for the most part, unless you have some drug interaction you haven't caught, or again, patients on too high of a dose, or things like that. And so what happens here is you actually have muscle breakdown, and that can lead to cases of rhabdomyolysis. And so rhabdomyolysis is just this severe body or muscle breakdown that occurs here. It can lead to impaired kidney function because all that myoglobin you're spilling out of the muscle cells can clog up the kidneys. Some patients have had to go on dialysis afterwards. And so this is where we really want to be cautious here. So especially if they have impaired renal function, mainly because not so much that the kidneys get rid of statins, it's more so the liver does that. It's more so that if they have already impaired kidney function to begin with, they might be more susceptible to having that myopathy actually affect their kidney function even worse, right? If they can't clear that myoglobin, it's going to be a problem. And so for those patients, you want to be cautious, maybe using the lowest effective dose we can, even though that's going to be a little bit at odds with our guidelines. We'll see in a little bit, and making sure we're avoiding things like combining statins with fibrates if possible, or if we do, make sure that we're reducing doses to mitigate those interactions. And definitely monitoring symptoms, right? So if you're going to go ahead and, if you have a patient who's complaining of myalgias and all that, have them come in, hopefully they're not calling you and saying, oh, I have tea-colored urine. That's kind of way too far gone in a lot of cases. But, if they call up and say, yeah, I'm just really feeling kind of crummy, my muscles all hurt, have them check a CPK, right? Or have them go into Quest and check that out. I could ask you what a CPK is, and I had some people that used to answer California Pizza Kitchen. Not quite what I was looking for in that case there, although quite tasty. But it means creatine phosphokinase, and that's a product that you'll spill out of the muscle when they do have breakdown occurring there. They do have evidence of that, evidence of elevated CPK and all that, then they would require discontinuation of the statin. Other things especially include hepatic disease. You do want to be cautious here, and you may need to avoid taking it altogether for some of those patients if they have a history of like hepatitis or alcoholic, hepatic dysfunction, things like that. You do want to be careful there. And then in terms of pregnancy, these are going to be absolutely contraindicated. You cannot use these in pregnant patients because if you think about it, like, what kind of, we use cholesterol and things like that to produce cell walls and whatnot. What kind of organism is trying to produce a ton of cell walls and trying to grow? It's a fetus, right? And so you can find severe teratogenic effects or fetal demise if pregnant patients take a statin. So these are absolutely a no-go. And then in terms of like relative contraindications, be careful if you're mixing it with other interacting medications here. So for instance, things like erythromycin we've talked about before being a strong CYP3A4 inhibitor. Some of the other medications we use for dyslipidemia we're also going to see can actually lead to reduced statin metabolism and can lead to higher levels and risk for side effects. So again, check your interaction checker. You can do that through things like Hippocrates. You have Lexicon, whatever you use, wherever you work at. Actually, I don't know what Advent Health uses for their drug reference of choice, but whatever it is, they're all going to have those interaction checkers. You can find out what could be possibly causing problems here. Okay, so again, whether or not you run into CYP3A4 interactions depends on whether the statin you're talking about is a substrate for CYP3A4. So things like simvastatin and atorvastatin, for instance, are CYP3A4 substrates. So anything that comes along and inhibits that is going to be a problem because they're going to raise up levels of those statins and can lead to myopathies and can lead to hepatic injury. So this includes things like, verapamil and amiodarone. We're going to talk about these drugs in the cardio section coming up, but certainly niacin and fibric acid derivatives can be problematic. These are going to be drugs we'll talk about in this PowerPoint here. And then grapefruit juice. You're like, well, why in the heck would I worry about grapefruit juice? All right, can you guys hear me? My power cut off for about a split second, so sorry about the delay there. Holy schmoly, that's the problem with live lecturing, I guess. You know, stuff happens. So anyways, I'm back. So hopefully, I don't know if that recording even up there. And of course, all my settings die out when the computer reset like that, so that was no fun. But regardless, we will carry on. So I think I was talking about grapefruit juice and in terms of issues that that can cause. So the reason why we care about grapefruit juice is because of the fact that basically this will act as a strong 3A4 inhibitor. And so, you know, a lot of younger people are not going to be drinking grapefruit juice commonly because it's pretty gross, but some people do like it. And especially older patients tend to enjoy it mainly because it's, you know, still something pretty strong that can tickle their taste buds, which may be less sensitive as they get older, as it turns out. I got this annoying chroma cam thing. Oh my goodness, this is annoying. All right, you guys are going to have to deal with that little thing. I don't have a chance to log in here. Yes. Anyway, okay, so I'm going to continue on. It's going to be annoying, but you guys have to deal with it. Anywho, so where do we like statins? Well, basically, these are going to just be the most efficacious agents we have here for lowering LDL, and you're going to find the guidelines recommend them first line for just about every patient, okay? All right, switching gears, we're going to talk about our cholesterol absorption inhibitors. These are going to be ezetimibe, so one drug in this category here. Notice that this drug is working specifically by blocking the actual enterocytes from absorbing the cholesterol, right? So blocking it from absorbing it from the intestinal tract. So it still gets absorbed. It's still working here within the actual cells, but it's blocking that cholesterol absorption. And overall, that helps to reduce hepatocyte cholesterol levels, right? So it's kind of reducing the levels within the liver. A different mechanism than the statins are, but kind of getting somewhat of a similar result. Although you're going to find that these don't work quite as well as a statin would, because instead of blocking direct production of cholesterol within the hepatocyte, this actually just blocks intestinal absorption of things like cholesterol. So it's not going to be as strong, but it can be an additional benefit there. So overall, because you have this less intestinal delivery of cholesterol to the liver, you're going to get better expression of the LDL receptors, and then you can suck up more of it out of the blood there, right? That's kind of the main thing we're going to see. And so actually the drug itself gets absorbed and will be eliminated through the biliary tract, and it kind of undergoes what they call enterohepatic recirculation. And the kind of benefit with that is it helps to limit systemic exposure. So you don't see a ton of like systemic side effects necessarily, but mainly relegated more so to the gallbladder and the liver potentially. So you can find either by itself or in combination with drugs. So you may see, like, for instance, like simvastatin plus ezetimibe to get some additional LDL lowering effects potentially. All right, so then looking at the effects here, you can see you get like an additional lowering effect. And I'll show you a chart that kind of compares all the different categories here in a little bit. So the benefits is like an extra 15-20% reduction in LDL when added to a statin. So generally not used by itself, but can be an add-on sort of medication there. So mostly you're going to find GI effects are going to be issues in terms of ezetimibe, you know, nausea, vomiting, diarrhea. But big thing here is you can look to see increases in transaminases with statins. So if you have a patient who's been on statin for a while, but they're not really where you want them to be, you can give them an additional boost with something like ezetimibe. However, you do want to monitor those liver function tests, right, to make sure you're not going to get unacceptable increases in AST and ALT and things like that. Okay. Now, these can interact with other medications in this class we're going to talk about. So that includes things like fibric acid derivatives, which can increase things like risk of cholelithiasis. You can find the bile acid sequestrants, which we'll talk about in a little bit, can actually decrease concentrations of ezetimibe, so that may lead it to be less effective. And then things like antacids can decrease the concentrations. We'll talk more about this in the GI section later on, but these tend to interact with the many medications and prevent them from being absorbed there. And some other interactions, you know, immunosuppressants like cyclosporin can actually increase concentrations, although you're pretty unlikely to run into patients that will have this actually come up. But again, antacids are freely available over the counter, so you may have a lot of patients taking these, and honestly, unless you ask them, you may not even know that they're taking them in the first place. Okay, up next is our fibric acid derivatives, otherwise known as the fibrates. This includes 3 drugs here, so you can tell they're fibric acid derivatives because they include FIB in the name, so FIB. So gemfibrozil, fenofibrate, or bezafibrate are going to be your fibric acid derivatives. So what do these drugs do? Well, basically, they're going to work here. You can see hepatocyte versus the muscle cells here, the myocytes. And you can see that they will activate with something called PPAR alpha. And basically, it's this nuclear transcription factor. And what that's actually going to do for us is will help to increase fatty acid oxidation. So you're increasing fatty acid oxidation, which leads to a decrease in secretion of triglyceride-rich lipoproteins, right? So basically, the liver is sending out fewer triglycerides, and so that means your VLDL concentration are going to go down, okay? So the biggest effect you're going to see here with the fibrates is you're going to get a big drop in your triglycerides, okay effect on LDL, but the biggest thing is triglycerides. And then you're also going to see this increase in expression of an ApoA1 protein, which actually helps to increase HDL coming in from, some of these remnants of cholesterol molecules coming in from muscle cells. So the two biggest things you see with the fibrates is a drop in your triglycerides and an increase in your HDL. So it's kind of his claim to fame for those two things right there. So you can see, okay decrease in total cholesterol and LDL, but the biggest things here are bumps in your which this should be HDL. I don't know what HCl, but HDL, and then your drop in your triglycerides. So very handy for those two things there. So you can have patients who have like a genetic, mutation to where they actually have really high levels of triglycerides, and really everything else looks okay for their lipid profile. And this would be like a really good set of drugs there. So if you have like a familial hypertriglyceridemia, this could be a good set of drugs for them potentially. Certainly can see gastrointestinal effects here. Some of the more things that are specific to the fibrates include things like cholelithiasis. So that could be worsened by drugs like ezetimibe, and then myopathies, right? And imagine if you put this along with a statin, those risks for myopathy certainly do go up. So you do want to be watchful for that and warn the patients of, what kind of warning signs to look for and things like that. In terms of contraindications, this is another case where pregnancy is going to be contraindicated. They have a history of existing gallbladder disease. This is not going to be great because this can worsen that. Or if they have severe hepatic or renal dysfunction, they're going to have a harder time clearing the drugs. So these would be things I'd want to watch out for before starting one of these medications. We'll talk about a set of drugs you can use specifically for pregnancy in just a little bit. So some other effects here you can see, certainly with drug interactions, be careful mixing fibrates and your statins. It's not a strict CYP3A4 interaction. There's some other metabolism effects going on here. So you can see increases in levels of your statins. You do want to be cautious with that. Usually if you had to start the two together, or if you had someone who's on a statin and you're adding a fibrate, typically you'd want to reduce down the dose of your statin beforehand to make sure that you're not going to run into these interactions here, right? Talked about ezetimibe causing some issues in terms of cholelithiasis. You can see some increased anticoagulant effects of warfarin. So some interactions. Again, you want to look this stuff up anytime you're prescribing a new drug for a patient, just to make sure you're not going to run into any problems, right? Again, where are they placed in therapy? Typically for patients who have very high triglyceride levels. And again, if you think about like a normal triglyceride, I think somewhere like 150 milligrams per deciliter, you can have patients here who have these familial hypertriglyceridemias with levels above 1,000, right? So very high levels. This is where fibrates help. Or if they have low HDL levels, you can help boost them up because we know HDL to be a protective sort of thing. Up next, we have our bile acid sequestrants, otherwise known as resins. These are going to be unique in the fact that these are drugs that, taken orally, have no systemic absorption whatsoever. They're basically going to be binding up cholesterol within the GI tract itself and preventing it from being absorbed. So this is different than ezetimibe, where ezetimibe is blocking it at the enterocyte, preventing it from being absorbed there. This actually physically binds it in the GI tract along with your bile salts, and that's going to help to just get rid of it in the feces, right? And so by binding up the bile salts and binding up some of the dietary fats you're taking in, the liver is going to have a relatively low level of cholesterol. So it's going to start to increase LDL receptor expression up at the cell surface. And it's also going to cause more bile salts to be formed as well to replace what you're missing. And so through those two mechanisms, that can be useful in order to get rid of LDL from the blood, even though it's only working in the GI tract. So as I mentioned, very handy here from that standpoint because it doesn't get absorbed. That limits systemic side effects. So this would be something that would be beneficial for patients who you did not want to have systemic actions on. So for instance, like pregnancy, for kids, this is okay because, it's harder to do a lot of good studies in children. And so this helps to limit any kind of systemic side effects that they may experience. And so may be preferred for that sort of patient population. So we have things like cholestyramine, we have cholestyramine, and cholesevelam are the three bile acid sequestrants you're going to see used most frequently. And so most of these end up coming either as like very large tablets or like powders and things like that. Let me put in Q day, shouldn't do that. Put in Q day. And so these are going to be less well tolerated by your patients because the dosage forms themselves are just not all that tolerable, as you're going to see. So either it comes like a gritty powder patients have to take with water or something. It's not great. So you're going to find that patient dissatisfaction with the medication is the biggest reason to stop taking it, as we'll see here in just a moment. So also there are going to be a lot of other problems too. So the powders themselves, you typically either mix it with water or fruit juice, but the texture of it is what a lot of patients don't really like there. So if you want to mix it with something like a pulpy drink, like some orange juice or something, that can help to mask that a little bit. And typically you want to take this within 1 hour of meals. And that makes sense why you'd want to do that, because that's when you have the most bile salts being released from the gallbladder. That's when you're going to have the most fat coming into the diet. So you take that within an hour of meal, and you have to separate it from other medications. Typically, you want to take your other medications maybe like an hour before, or you need to take the medications 2 to 3 hours, maybe even 4 hours after the bile acid sequestrant, because not only are those bile acid sequestrants going to be binding up fat in the GI tract, but they're also going to be binding up medications too. And so a huge source of drug interactions there, okay? The other problem too is because you have all this extra fat sitting there being bound up in the GI tract, you're going to see a lot of GI effects. So things like bloating and flatulence and constipation. Not great. And this is what causes a lot of people to stop taking it in the first place. And two, like, we mentioned, like, okay, well, these are the drugs that are the treatment of choice for pregnant patients. You think pregnant patients also want to have additional bloating, flatulence, fullness, constipation? Like, no, like it's miserable. So frequently, if we can focus on diet alone for those type of patients, that's going to be more beneficial from a patient compliance standpoint than utilizing something like this. But there may be some instances where that could be reasonable there. Okay. You can also have some issues with malabsorption of fat-soluble vitamins and folic acid. These are also really important for developing fetuses, so you have to address that. And then also, this can actually increase your triglyceride concentration. So if you had someone who had high triglycerides, this would not be the set of drugs for them, because that can actually lead to an increase in those levels there. So definitely avoid it from those purposes, okay? And as I mentioned, you can actually have some increased calcium excretion because it can actually bind that up as well. So a lot of electrolytes and vitamin deficiencies can occur here. So again, not used super commonly unless there's a very specific reason for it. Now again, these are going to interact with a ton of different types of drugs. They're going to be preventing those absorptions of things like digoxin, which we're going to talk about in a little bit, things like warfarin, thyroid hormone, beta blockers, all kinds of drugs are going to bind. So you have to separate it out. Either take the other medications an hour before the resin, or you have to do it 4 hours afterwards. Otherwise, the chances for absorbing it is just going to be too much. All right. So who are you going to use these patients in? Typically, if they are, who would you be contraindicated using these in? If they have increased triglyceride concentrations, say like greater than 400, this is just going to worsen that. And that can, again, even lower levels would be a relative contraindication. So if their triglycerides are high, don't use these medications, basically. And again, these are probably the safest overall because they have no systemic side effects, but also they're pretty poorly tolerated. And you're going to have to use them in conjunction with something else generally, because by themselves you're only going to get really modest reductions in LDL, so not great from that standpoint. Next we have niacin, which is going to be sort of our if you hear like nicotinic acid derivatives and things like that, that includes niacin, which itself is just a B complex vitamin. You'll see nicotinic acid being used as well, all kind of different names for the same family, essentially. And so you may see something like niacinamide used occasionally. This is actually not very effective as an anti-lipemic, so definitely make sure to avoid that. The thing with niacin is that there's a lot of dietary supplements that are made of niacin, and so this may be a good option for patients who are looking for something more quote unquote natural for them to take to help out with their cholesterol. And so this is something that's available. Just walk into a GNC or go into any kind of health food store, something like that, and they'll have these supplements available. And so this is important because you want to know what your patients are taking, what their priorities are. Maybe you want to try this first for them because they do want something that's considered to be more natural. That's perfectly reasonable. Just make sure you're getting the right types here because you don't want to screw that up. And you're going to see that in terms of what we have available to us, we have different varieties, immediate release, long acting. The majority of what we're going to run into are going to be the long acting forms. And that's a big reason for that is due to some side effects we'll see in a little bit. So typically you either want long acting or extended release niacin. It's actually pretty hard to even find immediate release niacin nowadays. Another form you might see as well is called inositol hexaniacinate, and that is something you may see occasionally. So what is this doing? Well, basically what niacin does is it helps to prevent liberation of free fatty acids coming from the adipose tissue. So you prevent mobilization coming from the fat, and that means you're going to have less precursors being sent to the liver. So overall, you're going to get less triglycerides being made here, okay? That means you're going to have less VLDL being produced, which will then have a downstream effect of having less LDL. And then you also end up getting higher HDL concentrations. So think about niacin in the same sort of use case as the fibrates. Decreases in VLDL or decreases in triglycerides and increases in HDL. Those are the two claims to fame for these two classes of medications here, right? Here's another picture showing sort of the same thing where you have less fatty acid mobilization from the adipose tissue. So you get less triglyceride synthesis. Overall, you're going to have some increase in LDL receptor expression there, but overall, you're going to get less triglyceride being produced and greater concentration of HDL being made. Okay, so that's kind of where it's being utilized most effectively. Here in terms of how we're dosing this, usually we're going to stick with the extended release preparations, which are just used one time a day because they're going to help to mitigate some of the side effects we're going to see with the immediate release preparations here. What are those effects? Well, basically, if you have something like immediate release niacin being taken, it tends to have kind of a peak dose effect where it produces a whole lot of prostaglandins. Those prostaglandins are going to cause a lot of flushing. It will cause you to be feeling hot. You're going to get nauseous. It's going to cause you to be sweating. You feel miserable. I've seen some people who've taken immediate release niacin and they look miserable. It's terrible. How can we prevent that? Well, how do you prevent production of prostaglandins? Well, something like an NSAID. And actually, aspirin is a really good option here. Aspirin can be taken as a pre-medication 30 minutes to an hour prior, and that can help to mitigate a lot of these effects here, okay? Other things you can run into, especially with bigger doses, includes things like increasing glucose levels because you can have decreased tolerance. Uric acid levels may be elevated. You can have some, increase in LFTs. So overall, those are things you want to be watching for in terms of monitoring for those patients there. But definitely if they're going to take immediate release, like as a supplement, dietary supplement, make sure they're taking aspirin along with that beforehand just to make sure they pre-medicate. Otherwise, they'll be less likely to be compliant with it. This is mitigated greatly by using an extended release preparation, so that way your levels don't really ever get that elevated as opposed to the immediate release. In terms of contraindications, we want to avoid this in patients who have chronic liver disease, where they have definite evidence of impaired hepatic function. And then in terms of relative contraindications here, if they have history of gout, hyperuricemia, diabetes, these are things you'd want to be cautious with, okay? Let's see, Madeline saying, my dad tried being healthy last week and took it and his face was sweating and red. He's no longer trying to be healthy. Oh, poor guy. Well, now you can give him a very important piece of advice. If he doesn't have a contraindication, not that I'm giving any medical advice out here. Obviously, this is all for educational purposes, but that is something that has worked for other people is take aspirin beforehand, and that helps to really mitigate that. But again, if you switch to an extended release preparation, which is another good patient counseling point, that can be mitigated. Some people may still be sensitive to it, even with extended release, but that is something to consider for sure. Again, you can see some interactions here with the statins where you can end up seeing increased issues in terms of increased LFTs. You want to watch out for that. These can certainly bind up with a bile acid sequestrant, so you don't want to watch out, and that will make your niacin less effective. And then ETOH or ethanol can actually make the flushing and whatnot even worse, right? So some people think about drinking alcohol, it kind of get hot and flushed. This can be worsened by niacin. Not that I imagine a whole lot of people who are trying to be healthy taking niacin want to consume alcohol at the same time, but you never know, right? So what do we use this for? Well, basically, this is going to be better for patients who either need additional benefit of lowering LDL on top of something like a statin, or if you just need to get the triglycerides down and the HDL up. Those would all be cases where it could be utilized. Okay. And again, you can see combination products being used all the time. So for instance, here's an example of lovastatin and niaspan put together called Advicor. Again, you get additional synergy in terms of drops in your triglycerides and increases in HDL there. So, but your risk for side effects do go up. So things like hepatotoxicity and myopathy, so you do need to monitor for that and certainly let the patient know what to look for. What could be some warning signs that some of these things are happening here. Right. All right, the newest class of meds we have here for dyslipidemia include the PCSK9 inhibitors. Includes two monoclonal antibodies, and so we have alirocumab and evolocumab. And so these are injectables because they are monoclonal antibodies, so they're proteins, they can't be taken orally, right? Everything else we talked about so far has been oral products, right? And again, dyslipidemia is a chronic disease, no need for IV medications for the most part, but this is an example of a parenteral product you can utilize here. And basically, this is an antibody that is engineered to bind to and neutralize this protein called PCSK9. And this is actually responsible for processing hepatic LDL receptors, meaning it will help to catabolize them and get rid of them. So by blocking the activity of this enzyme here, you can see that you'll actually prevent the breakdown of LDL receptors, so that way you have way more of them being expressed at the cell surface. You have a lot more receptors being expressed at the cell surface, and so that means you can be sucking up a lot more LDL out of the blood, okay? The more receptors at the cell surface, the more you can take out of the blood, the less your LDL is going to be there to be measured in the blood. And so you can actually see huge drops in your LDL concentrations. And actually, it's kind of interesting. There's a few in the clinical trial reports, some of the rare side effects. Actually, had some people had undetectable LDL concentrations. And it was so effective. It got the LDL to where you couldn't even measure it. We don't know if there's any clinical impact for that. Like, is that a problem? We don't really know. But it is interesting that they are quite so effective there. However, they're going to be way more expensive than any of the other products we've talked about so far because of the fact that these are engineered antibodies. Just by their nature of production, they're going to be much more expensive. And also, these are going to have a higher hypersensitivity reaction risk because they are proteins you're injecting into a patient. There is a risk patients could have an allergic reaction, so you do want to watch for that. So overall, you can see kind of a general feel for how these different drugs are going to be working to affect different components of your lipid panel here. And again, I don't expect you to know the numbers, but I would like you to know general trends and things here. So for instance, things like your nicotinic acid derivatives and the fibrates are going to have their greatest effect on HDL and the triglycerides. You know, the resins are going to have an increase in triglycerides, if anything, right? Statins are overall going to be very good, kind of the best, kind of first line therapy for getting down HDL or LDL concentrations, I should say. So again, these can work synergistically, but you have to be careful mixing and matching drugs because a lot of them can interact with one another and predispose the patient to toxicity, right? Some of that can be mitigated by dropping your dose, but it just depends on the situation and how sensitive the patient is, okay? All right. So again, looking at our lipid panel here, you'll find that VLDL is not something you measure on a lipid panel. However, triglycerides are, and that's actually just a direct measure of your VLDLs. And in fact, if you took your triglycerides and divided it by 5, that would basically give you your VLDL concentration. Not really so important for us, but just if you wanted to know how this stuff is calculated, that's how we get it. Now, beforehand, we used to go by these guidelines called the ATP3, and the main goal was to shoot for certain reductions in these values here. Like we want LDL down below 100 as being optimal. Nowadays, we realize because statins have all these additional pleiotropic benefits, we are not going to focus on the number so much. What we are going to focus, though, is to try to mitigate risk for death in these patients here. We want to try to prevent patients from having heart attacks, strokes, prevent them from dying in the future by reducing atherosclerosis, okay? So this is the new goal. So what has kind of changed from the ATP3 to the newer guidelines? Well, basically, you're going to find that patients are going to fall into one of 4 categories, essentially. If they fall into these categories, then they're either going to be recommended to start moderate or high-intensity statin therapy. Okay, I'll talk about what that is in just a moment. And so instead of looking at specific LDL target goals, we're going to try to get them on as heavy of a dose of statin as we can, as they can tolerate, because we know that the more intensive therapy they're on, the more potential benefit they're going to get from that. Okay. And so if we're measuring lipids, chances are we're going to be doing that more so to assess adherence to treatment, more so than just seeing if we can get their LDL to a certain goal. What that means is if you put someone on, for instance, 40 of rosuvastatin and you don't see any drop in their LDL, they're just not taking the drug, right? There's no way they can be on that intensive a statin and not see big drops in their LDL unless they're not taking it. So I'll show you some examples of that in just a few moments. So who are the 4 major benefit or statin benefit groups here? So individuals with clinical atherosclerotic cardiovascular disease. Have they had a heart attack before? Have they had a stroke before? Have they, they have peripheral vascular disease that is sort of an equivalent for atherosclerotic cardiovascular disease. These are all things we would consider the patients to have the biggest risk. So if they have a previous MI, then yeah, or if they have angina, yeah, of course they're a huge risk there. If their LDLs are greater than 190, if they have diabetes and they're between the ages of 40 and 75 and they have these LDL concentrations between 70 and 189 and they're without clinical ASCVD, because we know that if you have diabetes, your risk for cardiovascular disease is going to go up regardless. So those are definitely patients who could benefit. And if they don't have, if they don't have ASCVD or diabetes and their LDL concentration is somewhere between 70 and 189, which is basically going to be all your patients, and they have an estimated 10-year risk greater than 7.5% of developing atherosclerotic cardiovascular disease, those patients can also benefit. Okay, so it's pretty easy. Do they have existing cardiovascular disease? Do they have really elevated LDLs? Do they have diabetes? Or if they are missing all the other things, do they have a 10-year estimated risk greater than 7.5%? I'll show you how that's calculated here in just a moment. So basically, you can kind of see it goes by this algorithmic sort of approach here in terms of determining how these patients are going to be managed. And so the main group here you're going to be focusing on is the 40 to 75 year olds. And then, of course, anyone greater than 75 obviously is going to be at big risk as well, which we'll talk about here in just a few moments. But basically, say, for instance, you have someone who's age 40 to 75 and their LDL is, between 70 to 189 there, and they're without diabetes, right? This is the group where you're going to actually be looking to see what their 10-year risk factor is. And again, if they're relatively low risk or borderline, you're still focusing on things like the non-pharmacologic stuff, lifestyle modifications, weight loss, all that good stuff. But based on how high their risk is in the next 10 years, that's where you're going to focus more on statin therapy to try to get their LDLs under control, to get additional pleiotropic effects of the statins there, right? If they have diabetes, they're going to need a statin most likely, right? If they have a history of ASCVD, they're going to need it. And again, you can see here some examples of what those risk enhancers are, things like that may lead you to bigger risk, more likely to go ahead and go with the statin therapy here. So, or if they have a history of ASCVD, so a history of like heart attack, things like that, certainly focus on healthy lifestyle. If they're at very high risk, this is where you want to focus on maximal intensity statin. I'll show you what those look like in just a little bit here. But basically, you're going to start most of these patients out on statins. If they're not able to get things under control with just that, or they can't tolerate it, that's where we're going to focus on some of their other medications, things like the PCSK9 inhibitors, things like ezetimibe, potentially, depending on the situation there. The big thing you have to watch out for is if their age is greater than 75, they're going to be more prone to some of the side effects of statins, like the myopathies and increases in LFTs. And so you may need to try to modify their dose down first to see what they can tolerate, and then try to titrate up to see whatever they can really tolerate in that case there. So again, am I going to necessarily like give you kind of a very gray sort of case here to be like, okay, you have a patient who is, 45 and they don't have diabetes and no cardiovascular disease and the risk of 7.5%, what are you going to put them on? I'm not going to get that granular with it, right? But I will ask you, like, here's a really high risk patient. Like, what kind of statin therapy do they want them to be on? This guy's diabetes. He had a heart attack 6 months ago. His risk is 12.5%, or whatever the case may be. It'll be pretty clear cut in terms of what you need to utilize for that patient there, right? Here's an example how they would actually measure your 10% risk. So you can find these calculators online here. But, putting in risk factors like male versus female, obviously being a male is going to put you at bigger risk. Your age, ethnicity can affect this. Total cholesterol, HDL, systolic blood pressure can put you at bigger risk. If they're on treatment for blood pressure, diabetes, and if they're a smoker. So all these things would basically spit out to you a percentage of chance that they can have atherosclerotic cardiovascular disease in the next 10 years. If it's too high, then you go ahead and start the mifenystatin therapy. So this is more the important thing I wanted to focus on here is what do they consider high versus moderate versus low intensity? There's really only 2 drugs that fit on the high intensity scale, right? These are the 2 most potent statins in terms of getting down your getting down your LDL by more than 50%. That includes atorvastatin and rosuvastatin. Okay, don't worry so much about the doses here. I'm not going to ask you anything like that specifically, but basically these 2 are important. Now remember your drug interactions. If you have to have a patient who's on a CYP3A4 inhibitor, then rosuvastatin is going to be the better option here because it does not get metabolized through CYP3A4. Atorvastatin does. So again, that's a consideration you have to make there. What other interacting medications might they be on already? Okay. In terms of moderate intensity, most of these are going to fit the bill here. So stuff like your lower doses of atorvastatin or rosuvastatin, simvastatin, all that good stuff. Most everything is going to fit on this bill here. Whereas low intensity, there's not really many patients who are going to be recommended that. But the thing is if you start a patient who is indicated for moderate intensity statins and they can't tolerate it, that's where you'd want to then bump them down based on their dose to something maybe more low intensity, depending on how they're responding. Like, what are their LFTs doing? Are they having myopathies? All that sort of thing. Okay. So overall, again, select the appropriate dose based on what the recommendations are and try to keep them as high intensity statins as they can. If they're not able to tolerate that and you can't get your LDLs under control, then that's where you may add on additional medications. But know if you have, low HDL levels or if you have high triglycerides, know for those patients there, they may benefit from something like niacin, from something like a fibrate. Just depends on the patient, kind of what their profile looks like there. So overall, that's going to be it for this section. Do you guys have any questions about that? So I'm going to switch over to thing here. So if lovastatin and simvastatin are prodrugs, why is their bioavailability so low? It has to do with, could have to do with a lot of different things. Could have to do with even if it is getting metabolized in the liver there to the active form, perhaps then you could even still find that there could be some additional metabolism happening in the liver that can reduce the bioavailability. Or you may just have the drug itself doesn't get absorbed super well from the GI tract. It's a very case-by-case basis, but not something I'm going to really be harping on too much for the testing purposes, because it's not like we have IV forms available, so it's not really that would even matter. Okay. Can statins be used to prevent and treat atherosclerosis? Yeah, so that's essentially what you're doing, right? Because it's not so much that I care to get the LDLs down. The point is, like, what are those LDLs doing? And it's working to enhance the atherosclerosis. It's working to increase inflammation, narrowing those vessels, leading to plaque ruptures and all of that. And so that's what the statins are being used for. So even if you had a patient who had relatively, if you go back to, say, for instance, this slide here, so someone who does not even have high risk, looking at them, without evidence of cardiovascular disease already, even if they are relatively, if they don't have evidence of atherosclerosis, but they still are at a high enough risk based off things like their blood pressure, based off things like they're a smoker and all of that, that's what's going to lead them to want to consider initiating moderate intensity statin therapy, because they know the road they're heading down, and so they know that they can try to help stabilize that stuff early. That can help to reduce their chance of risk pretty significantly. Right. All right. Is there an LDL target level in high-risk patients, like less than 100 in patients with diabetes? There's not a specific number goal they're really looking for. It's more so they just want as intensive a statin therapy as possible. Typically, you're looking for, and if you look back at the slide, excuse me, trying not to cough in you guys' ears, that would be kind of rude. Looking at this here, if they're indicated for high intensity statin and they're not getting greater than a 50% drop, that's where you may consider adding on additional medications there. But there's not really a specific number. We just know that the better intensity statin they can be on, the better their chances are. But it's always that risk benefit analysis of trying to mitigate their risk for toxicity versus the benefits of the drugs themselves, because they work great, but it's one of those things where the risks are there. You do have to watch for it. Some cardiologists probably want statins to be in the water supply, but there are a lot of risk with these drugs, and they can be fatal if not kind of managed appropriately, right? Would you be able to quickly review the quiz? I'm not going to go over specific questions, but if you do have questions about anything in particular, feel free to email me. I think the questions are fairly straightforward in terms of stuff that I might ask, like on the test. or things that I think are important, like for instance with the matching stuff. But I'll have to review the stats to see if there are any high miss questions. But it didn't look like it was just based off of the how you guys did overall. But if you have questions, feel free to email me for sure. Some stuff for the CYP interactions. Is dairy one of those, or just the options listed underneath, or vitamins? So in terms of CYP interactions, dairy itself does not interact. The problem with dairy you're going to find is that calcium likes to bind to a lot of things, and so that's where you may run into interactions there. In terms of CYP interactions, I just listed some of the more common ones, and so that's what you're going to see there. In terms of vitamins, also calcium-based vitamins, iron, all of those tend to bind to medications as well, so that's where you could see some interactions. It's still a kinetic interaction because it's affecting the absorption, but it's not a metabolism interaction there. That makes sense. All right, what other questions do you guys have? That was a relatively quick session, but got the quiz out of the way there, and I can let you guys go early on your Friday. But if you have questions that come up, feel free to let me know. Sorry about the power outage. I unfortunately have no control over that, but I think we were covered well enough anyway, so I guess we're all good. If no other questions, feel free to head out. I know we'll see you next time, but I'll stay on for a minute or two just to see if anyone has anything popping up here. Yes, thank you. Why are bile acid sequestrants called resins? That's a good question. So this has to do with they're called an anion exchange resin. So basically, what this means is that it's able to, usually it has some kind of ion attached to it, usually like a sodium or something like that, and it's able to exchange that to bind to something else. And so it's able to bind to the bile salts in this case here, to bind to them. When that binding occurs, then they just get eliminated into the feces. So the resin is sort of like the dosage form that it is. It's a description of the actual product itself, I guess. If you ever look at like Delsum, that's an example of another exchange resin. Delsum is Robitussin, like we talked about. There's something called sodium polystyrene sulfonate, or SPS, sometimes called K-exolate. That's another exchange resin that actually exchanges sodium for potassium for patients with hyperkalemia. So there's a few examples of that you'll see occasionally. All right, that looks like about it. So thank you guys for joining me, and I will see you all next time.